Yeah, I'm ready if you all are.
Hey, good morning, everybody. Welcome to Alabama EMS Challenge. We've got Dr. Shea Duerring here today at Children's Hospital. Going to talk about some pediatric issues, and we're glad to have him. Always glad to hear about peds. This is actually one of our most requested topics on the feedback form, so we'll have a recording of this as well. Go up on the YouTube channel a little bit later. Dr. Duerring.
All right, guys. So let's go ahead and kick off. We'll talk about pediatric trauma as our selected topic today, and then we'll move on. The second half, we'll talk about peds cardiac arrest resuscitation, and I'm going to say some new stuff and some fun stuff that's going to challenge some people and probably make Wes have a little seizure, but that's all right. Oh, what am I doing wrong here, Wes? Wrong button, apparently. There we go. All right, so we're going to talk about trauma. So you got a 2-year-old female. This is a real case, by the way. Improperly restrained in a car seat. Vehicle rolled off into a ditch. On arrival, she's trapped, unable to obtain vitals, but she's alert. She's really fussy. She's responsive. Has a prolonged 45-minute extrication from the vehicle. And after extrication, mental status has changed, and she's now unresponsive. Those are her vitals. That's her exam. She has a big old goose egg over the left parietal scalp. Bunch of facial swelling and multiple facial injuries, bruising over the left chest, and deformity over her left thigh, and just abrasions, covered in abrasions and glass marks everywhere. Who gets really excited about this patient? Nobody, right? So, what kind of injuries are we concerned about? She pretty obviously has a goose egg over her head. We know kids are really prone to head injuries. What else? She has some bruising over her left chest, but no deformities. So are we still worried about potential chest and lung injuries? We know she has a deformed thigh and femurs. Kids can lose a lot of blood through their thighs, just like adults can, even more so because they're more expandable. And so we got a lot of stuff we need to worry about. What are our first priorities? How are we going to manage this kid? So we're going to talk a little bit about all of that today. So these are the top things that kill kids. What do they all have in common? They're basically all forms of trauma, right? Trauma is the number one thing that kills children, both in the state of Alabama and nationally in this country. Not surprisingly then, trauma is the number one call for EMS for kids. And so most of the kids that we see, a big chunk of them, are trauma, injuries of some kind. And so it's important that we talk about trauma because while the general principles of trauma are the same, right? You got to make air go in and out, and you stop the blood from going out and make it continue going round and round. There are some things about kids that are different that make their management a little challenging. And so these are the things that we need to talk about with kids for trauma. All right, so again, trauma is the leading cause of death in children over around a year of age or less, over a year of age. And unintentional injury accounts to 15 to 20,000 deaths annually in the United States. That's 30 to 50 kids a day who die of unintentional trauma of some kind. Okay? Again, number one killer of children in Alabama by far. There's 9.2 million medical visits for unintentional injury among U.S. children and accounts for over 150,000 hospitalizations for kids. So if you think about this in terms of time of missed work for families, dollars for admissions, dollars for missed work for family, it is by far the number one economic challenge for children is and spent dollars is in trauma and unintentional injury. And again, 15% of all hospitalizations for unintentional injury result in permanent disability. So this isn't just a survival issue, it's also a quality of life issue, okay? So when these kids are managed well and managed appropriately, hopefully we can't really stop this part, right? We can do community education, we can do things to help prevent trauma, but this is where we have the impact, right? This 15%. Because if we can manage these kids well and manage them appropriately, we can keep them alive and hopefully we can get that number down. We can change that 15%. So those are the ones that we can make the difference on. Again, we talk about trauma and we talk about the trimodal distribution of trauma. And that is there are 3 peaks of when you die essentially in trauma. There's the people who die immediately, okay? The just overwhelmingly devastating injuries that just die essentially on impact or die immediately after their injury, okay? We can't really fix those, all right? There's the third peak, which occurs later days out in the hospital, where they die of sepsis, multi-system organ failure, things related to their injuries that are managed in the ICU. But there's this second peak here that occur within minutes to several hours, okay? Again, these are the kids that we can change. If we can keep these kids in the second peak alive and do a good job, then hopefully we can reduce that number as well, right? So these are the immediate ones. This is, I was thrown headfirst into the tree off the ATV and there is no survival, okay? These are the ones we can't change, the immediate deaths. The ones that occur a week to 4 weeks out, so they die of complications related to those injuries later on. And then there's the early deaths. This is the peak that we can affect, and then hopefully by doing a good job, decrease that 15% disability rate a little bit. All right, so kids aren't just small adults, right? Sometimes though, they do look about the same. So unique problems. Children are simply, again, not just small adults. They have different injury patterns. They have different presentations in their physiology. They have management differences, and their differences in size. So the size is where we come into a big difference. Because they're smaller, remember that energy increases over a smaller surface area, right? So if I get punched in the gut, I got a big old surface area if you punch me in my gut, that helps dissipate that energy, right? But if I take a 6-month-old and they get hammered in the gut, that energy gets transferred out over a much smaller surface area. And so they take a more direct translation of that energy, right? And so that energy leads to more underlying injury, more internal injury, and more damage. And they have less fat and soft tissue that helps them kind of absorb that energy too. And so these kids, even with smaller sort of mechanisms, can still get some pretty significant underlying injury. Their skeleton is different. So it's less calcified and it's more flexible. Okay, so when kids break bones, they don't always get this snap twig at a 90-degree angle like we think of with fractures, right? They get green stick fractures, they get buckle fractures, things that are injured in abnormal bone, but not necessarily snapped in half, okay? So they have a higher rate of skeletal injury, but that also means because that skeleton is flexible, they have a higher rate of underlying injury without necessarily a lot of outward signs, right? So their rib cages are still really soft and flexible. So everybody's seen old Looney Tunes cartoons where Wile E. Coyote gets punched in the chest and it like caves in and then pops back out. So kids actually do something not that dissimilar to that, okay? So if you have a big bruise over their chest, but you go, oh, well, no crepitus, no flail segments, no big broken bones, they should be good. They actually can have pretty significant underlying lung injury and pulmonary injury from that without all those outward signs, because their rib cages, it's so hard to break their ribs because they're so soft and flexible. Same thing's true for the upper liver. You know, the liver is sort of tucked under a little bit of the rib cage, especially in kids. And if that gets hit, they can actually suffer some liver damage from that flexible bone, because it kind of bows in, they get a little damage and kind of bows back out. And therefore, they also have greater incidence, like we just talked about, abdominal chest injury without accompanying fractures and sort of overlying injuries. They have high surface body volume, which means they dissipate heat quickly. And we all know that shock does not like to be cold, right? Shock will get worse progressively and quickly when you get cold, especially in kids who really, really like to, and babies who really love to be kept warm and at a really steady temperature, okay? So temperature control is really, really key in my population, especially my little babies. If you take patients into the trauma bay at Children's, the first thing you notice is how freaking hot it is, right? So we keep those rooms at 88 degrees minimum. All right, plus they automatically get the little heat lights turned on over top of the table when we come in. And so those kids are kept nice and warm, okay? And that is because we have to. They will dissipate that heat, their shock will worsen, they'll get sicker. Especially these kids who are exposed, who are in the elements, who are maybe trapped for 45 minutes like our patient, they will start to get pretty sick quickly just from that exposure, okay? So do everything you can to keep them warm. Heated IV fluids, burgers, heat, whatever it is you need. All right, so when we talk about trauma, we talk about ITLS, PHTLS, whatever the new TLS that we teach now is, because there's been like 18 different ones over the time. We talk about the primary survey, right? The ABCDE and going through that primary survey. And so we're going to talk about things about kids that make them a little different, that affect their management, looking in trauma, looking through the lens of that primary survey, because the whole point of the primary survey is to quickly identify and intervene on things that are immediate life threats and potentially causing serious injury and damage, right? So these are the things that we really want to make sure we know how to manage really well and really effectively. So the first is airway maintenance, and remembering that airway maintenance has to involve cervical spine control, right? So we can't just take this kid, if we're going to intubate them or put an eye gel in or whatever, and kind of crank their head back, right? Like we normally would, get them into that extended sniffing position. Remembering that cervical spine control, even with airway maintenance, is still really important. And airway in general for kids is really important. Think of their different anatomy. Kids have big heads, small necks, floppy tongues, big upside down kind of U-shaped epiglottises. Anyway, and so they are really prone to airway occlusion, okay? And so, and the most common cause of arrest and death in trauma is actually inability or to manage a child's airway. So their airway going bad. It is the single most common cause of arrest and death in trauma amongst kids, is their airway goes bad, they get hypoxic, they arrest, and things go downhill quick, right? Because we all know the rate of traumatic cardiac arrest survival, whether you're a kid or adult, is pretty poor, right? Under 1%. So things start to go downhill really, really fast once the airway goes. Again, their airways are just different, and so they're really, really prone to occlusion, and then we have to figure out how to manage that. Remember, their subglottic trachea is the narrowest part of their airway, unlike adults. And so that does affect how we pass tubes and do things. Airway control is, again, our first priority. It's A for a reason. We talk a lot about cardiac arrest now and talking about CAB and moving that around and changing things. Trauma is still good old ABC alphabetical order, okay? We have to control that airway, because again, it is the thing that will kill them the most and kill them the quickest in kids. So airway control is our first priority, remembering with C-spine control. Controlled airway recommended in the following. None of these are new or shocking to anybody. If they're altered, severe facial injuries, respiratory distress, chest injury and multi-system trauma, and significant trauma with a anticipated prolonged transport. So if this kid, big multi-system trauma, looking bad, and you know you've got an hour ride to the hospital, maybe a good indication to manage that airway. So clear the airway, obviously, suction, getting teeth out, getting whatever might be foreign object in there. And then jaw thrust, obviously starting with our BLS airway maneuvers, simple stuff first. We don't want to be careful with using nasal airways, right? Because kids are really prone to head injury and basilar skull fractures. And so we don't want to necessarily stick nasal airways up their nose. We generally always just sort of consider trauma contraindication to those. Oxygenate them and ventilate them. You've got to prep your patient. We're going to talk about why this is of paramount importance in just a minute. But oxygenate and ventilate your patient. Kids in general are pretty easy to bag, trauma or otherwise, okay? And you've got to bag them up. You've got to start correcting some of their hypoxia. You've got to start correcting some of their physiologic derangements before you attempt to control that airway, unless you're just in a crash airway scenario where they're arresting immediately in front of you, okay? And we're going to talk about why this is so important. And then intubation, whether that's with an ET tube or an eye gel, or in the pre-hospital setting, depending on your transport time, maybe a BLS airway, and that's fine and totally reasonable, knowing that you've got to keep a close eye on that airway and control it appropriately. And then obviously can't intubate, can't ventilate, our last ditch effort is needle cracking kids. So oral tracheal intubation is the gold standard. We generally don't talk about nasotracheal intubation because of the high rate of head injuries and talking about basilar skull fractures. Everybody at some point has seen the picture of somebody who had like an NG tube, the x-ray of the NG like coiled up in the cranial vault. Nobody wants to be that person. And current ATLS recommendations for rapid sequence induction and intubation, but don't forget to pre-oxygenate and to manage your patient as much as possible before attempting it, okay? And we're gonna talk about why in just a second. Airway complications are as high as 25% with pediatric field intubations in trauma patients, okay? And so we know that we've had issues with this in the past. It is a tough skill to perform, okay? It is a tough skill to perform reliably. It is a tough skill to perform when you don't get a lot of practice. Most paramedics will intubate no more than 1 to 2 kids throughout their career. And currently, in the past, when we had fewer medics and more things going on, that may have been that number was different. But currently, with large EMS systems spreading out the number of intubations and intubating just fewer patients now, and not going into ORs like we used to, like when I went through paramedic school, then you're not getting as much intubations for kids. And most paramedics will only intubate a handful of kids at most in their career. And so it's something we don't have a lot of practice and experience with, and that affects our success rates. There is no difference in survival with adequate mask ventilation versus intubation as long as you are controlling your airway appropriately and getting a good seal and doing what you need to do. Okay, so eye gels and Keen tubes may provide effective airway control in the field until definitive airway can be obtained. All right. Again, newer supraglottic airways are really, really effective. They're really easy to use and they work very, very well. Okay. There's no studies looking specifically at pediatric trauma and supraglottic airway though, okay? But we know they work really, really well for adults in trauma, and we know they work really, really well for kids in cardiac arrest and other things. And so probably they work pretty well for kids that are trauma as well. We just don't have anything to tell us that for sure. All right, so again, kids can be tough. This is looking at the National Emergency Airway Registry. This is looking at kids who are intubated in emergency departments by emergency medicine physicians, okay? Kids and adults, actually. And so look at these number of airways. So 17,000 adults to only 1,000 pediatric airways. So that tells us even ER docs don't get a ton of practice with pediatric intubation, okay? Because look at the difference in those numbers. And then first pass success was about the same, all right? But first attempted failure in infants was 2.3, risk ratio of 2.3. So if you took out the older kids and looked only at infants and little kids, this number drops to about 40%, okay, for your first pass success rate. Overall success rate was still good and about the same. But the point is that these little kids are really, really, really difficult, okay? And that's using traditional RSI, which we know sets you up for greater success, which we typically don't always have access to in the field, okay? And so the point is that these kids can be really difficult to intubate. It's an invasive technique with little room for failure. Like we talked about, we haven't always been historically so good at it. So if we're going to do it, we've got to do it as best we can. We got to prep our patient. We were talking about this a minute ago, okay? And this is why it's so important to prep your patient. The idea of RSI is a good one. The idea that we're going to sedate, paralyze, intubate, and create optimal intubation conditions. But the idea that we can't control the airway by other means while we correct some of the patient's physiologic and hemodynamic derangements is the problem. This idea that we got to go straight to rapid sequence induction or intubation because it's rapid, that R needs to disappear, okay, in kids especially. And here's why. So we look at post-intubation hypotension, all right, and look at this, for kids and adults, and we know that post-intubation, that one episode of hypotension, especially in head injuries, drastically increases your morbidity and your mortality, okay? So incidence of post-intubation hypotension, looking at over 20,000 airways in emergency departments, okay? 66 out of 300 or 22%. All right, a shock index of greater than 0.8 was highly predictive of post-intubation hypotension, okay? And these are adjusted shock index rates for kids down here at the bottom, okay? The idea, though, is the same. The numbers are a little different, okay? Forget 0.8, that's really looking at adults. But the idea is the same. If your kid is in shock, if you're starting out behind the 8 ball when they're hypotensive, tachycardic, circling the drain, then the chance of them experiencing post-intubation hypotension is exceedingly high, okay? And that's a problem because secondary injury and TBI from post-intubation hypotension is significant. A prospective study looking at 717 patients with severe TBI, if they had one episode of hypoxia or one episode of hypotension post-intubation, yes to either one of those, then there's a 150% increase in mortality related to your TBI, okay? 150% increase in mortality with even one episode of post-intubation, either hypotension or hypoxia, okay? So for kids who are frequently intubated secondary to head injuries, maintaining that blood pressure and maintaining their SATs are incredibly important, okay? We have got to do that in order to reduce our mortality, but that's also the biggest way that we can decrease that 15% number, right? Because the ones who survive it, also, by the way, this gave you a 200% increase in your morbidity, all right? So we have got to prep our patients. In kids, more than ever, it is so important to make sure that we have prepped our patients for their airway management, okay? So can you get by with a BLS airway and good bagging while you obtain vascular access, start resuscitating, get their SATs from 70 to 98, and to start doing things that set you up for better success and also sets your patient up for better success, improve morbidity and mortality. Yeah.
Hey, Doc, so I got one question that came in. So what's the cause of post-intubation hypotensive, and can it be caused with a oral airway adjunct?
So typically it's related to two things. We all know that when you're bleeding in your trauma, your preload is down, right? And kids are very preload dependent. And so there's two things that cause it. One, typically the drugs, the sedatives related to intubation, okay? So if you're giving them a big slug of, fentanyl or which is a little hemodynamically, we think of as hemodynamically neutral. Kids will get a little hypotensive with it though, more so than adults. Or Versed, which has typically been used a lot in the past. Versed will tank a kid's preload. The other is that, remember, once we intubate you, and we start positive pressure ventilating, we increase your intrathoracic pressure, right? We decrease that preload. And so there's a couple of things that relate to that, but and that's why tanking them up, getting that preload up a little bit, and making sure that we are using friendly agents is really key. Does that make sense?
I think so. So I think where we're going with this question is, are we going down the same road using BLS techniques? For example, you'd still have an increased intrathoracic pressure just using a BVM.
Right.
So in other words, where's the comparison between intubate versus don't intubate, especially if we're not using drugs to intubate?
So the comparison to intubate and not intubate is, can you manage the airway, basically? So yes, you will increase some intrathoracic pressure with intubation. Absolutely. You also do it with BLS airways. That being said, you've got to ventilate your patient. And so that and BLS management is not a direct, there's not the same correlation in increase in intrathoracic pressure as there is with a direct ET tube down in your lungs, 25 of PIP with 5 or 10 of PEEP, and how that sort of changes your hemodynamics. And so you're probably a little safer with a BLS airway as far as the increase in intrathoracic pressure. And then the big thing is picking drugs that are friendly. And we'll talk about that in a second. But So we have to prep our patients, because it's okay, again, shock index of greater than 0.8 or greater than 1 for kids really is really predictive of post-intubation hypotension. And so the point is, if we have a kid who's already shocky, should we be immediately moving straight to intubating that kid and doing things that alter their hemodynamics before we've optimized them for that procedure? Make sense? So choose your drugs carefully. Things like Versed, propofol really affect preload, and kids have significant hypotension in response to. Things like etomidate and ketamine work great. And in fact, you normally get a little blood pressure bump out of ketamine. And this dogma that ketamine can't be used in head injuries has been disproven 1,000 times, and we can move on from that. I'm pretty sure if Ferg was here, he'd be nodding his head and like stroking in the corner, but just because I even mentioned it, but it's gone, okay? Consider push dose pressors, okay? These are ridiculously helpful at quickly and easily managing post-intubation hypotension, okay? Consider having them ready even before you intubate, okay? We can do a whole talk about push dose pressors because they're a big hot topic right now and everybody likes them. And they work really well, okay? They're great in the EMS setting where we have we don't hang a lot of drips. We're not used to drips. And a lot of times by the time we can get a drip mixed and set up, the post-intubation hypotension, which tends to be transient, has already resolved. So these can quickly and easily be used for kids to give them a little push and a little bump to quickly get over that hump, while you either A, get your drip together, or B, hopefully don't even have to worry about it by that point, okay? Again, consider deferring intubation in certain cases, and then pre-oxygenate the patient as much as possible. Again, bag them up, get them in a good place, using apneic oxygenation during intubation, all the things that we know can be helpful for preventing desaturations, because that will help prevent that post-intubation hypoxia or peri-intubation hypoxia, and that will help us decrease morbidity and mortality. Since again, a lot of these kids are going to be getting intubated due to head injury. So again, sedatives, etomidate and ketamine work great. They're really useful. Versed and propofol can be tough on kids. Again, they're really hard, especially on trauma kids. They get hypotensive with it. Paralytics, looking at sucks or rock. We tend to not use a lot of sucks in kids. That is because babies under 1 can have a really high rate of getting this profound reflex bradycardia in response to succinylcholine. And so we just sort of years ago in kids, in peds, got away from using as much sucks, and we never really went back. It's a good drug. It works really well. It does its job quite effectively, okay? And if you can't get the airway, it wears off a little quicker than rock, okay, which is nice. But be careful with kids under 1 because they will there's a high rate of them tanking their heart rate in response to that. Use cricoid or laryngeal manipulation to enhance your view. Use video laryngoscopy if you have it. Video laryngoscopy has been probably the greatest advent in airway management in the hospital and definitely in the pre-hospital setting, probably period, at least in the last 15, 20 years, okay? Video laryngoscopy is so key. Your rate of first pass success is absolutely the highest in pediatric intubation using a video laryngoscope and a bougie. In fact, it is almost a 2-fold increased success rate and almost 4-fold increased success rate over either traditional laryngoscopy or traditional laryngoscopy with a bougie, okay? So success rates are drastically higher with video laryngoscopy and a bougie when intubating children, okay? It is the most effective way to increase your first pass success and to do it quickly and effectively. Remember to not obstruct your view when passing the tube. That's a lot easier to do when you're using a video laryngoscope. When you're using a traditional one, people always have the habit of wanting to shoot that tube down the flange. And kids who are anterior with those big arytenoids in their airway, invariably what happens when you've blocked your view is you hit those and that tube bounces down into the esophagus and you don't realize it because you've obstructed your view. Confirm your tube with capnography. And remember, your tube should be about 3 times the diameter of the tube. And ongoing monitoring with waveform capnography is absolutely the most essential thing that you can do once you intubate a patient. The high rate of tube dislodgement in kids is incredible. It approaches about 60% dislodgement rate for field intubation of kids. And way before that kid starts to get hypoxic and circle the drain, what's going to happen if you're using waveform capnography? You are going to know it instantaneously because that waveform is going to go and your CO2 is going to go because you are no longer getting any gas exchange, okay? Waveform capnography is absolutely key to managing the airway. Again, this is a bougie. Most everybody uses these now. I think these have been seen by everybody. These things work great, drastically increases your first pass success rate. This is how I intubate people in the ER. I preload my bougie and essentially use my bougie as an intubation aid and the stylet for my tube. It is so easy to do. It works incredibly well. They make pediatric bougies that will take down to really a 4.0, but if you lube it well, a 3.5 tube, okay? Because I've been there and I've done that. And they work incredibly well. This little hook is really helpful because it helps get up into that really anterior larynx, right? Because normally people who have intubated kids, and my residents and fellows do this all the time, right? You have this great view, but it's kind of anterior, and you're sitting there with the tube and you're trying to flick it up, right? Get it up into that anterior airway. So that hook on the end of the bougie, great, slides right up in there, okay? And then it's also a nice secondary conformation because you can click those cricoid rings. It's actually what the point of that thing was for. And so it's a nice secondary kind of tactile conformation you're in, and then you just tube over. And again, highest first pass success rate. Video laryngoscopy with a bougie versus traditional laryngoscopy with a bougie, 82 versus 96% first pass success rate. So we're going to intubate these kids. And we know that if they get hypotensive or hypoxia, we're increasing their morbidity and mortality. Obviously, we want to do whatever we can in order to increase that first pass success rate. We want to get the tube in, we want to get them ventilated. Okay, so VL with a bougie is by far the way to go. All right, B and breathing. Assessment of their breathing, again, thinking about sort of assessment triangle stuff, right? So as appearance, work of breathing, circulation, thinking about that work of breathing triangle leg. Exposure, rate, looking, breath sounds, symmetry of breath sounds is a big thing because kids, their mediastinum, things aren't as fixed in their mediastinum. So if they drop a lung and they get a pneumothorax, they will more quickly develop tension physiology and obstructive shock related to a pneumo than an adult will. So assessing for those good bilateral symmetric breath sounds is really, really key because if you have a pneumo, you need to know that and you need to be ready to manage that. What's up, Wes?
I've got a couple of questions came in. Sorry for the delay, guys. There's a little bit of a delay between when we talk and when you hear it. But so somebody asked depth 3 times the diameter, question mark, question mark.
Yeah.
So I've actually never heard that either. So you mean depth and
So 3 times the diameter of the tube. So if you're working with a 4.0 tube, generally it should be around 12 at the kind of teeth lip gum, depending on how old your kid is and where you're measuring.
Okay, so the depth in the centimeters that are marked on the tube.
Correct.
All right, and another question was, is atropine still recommended pre-intubation in peds?
It is not, and has not been shown to be really that effective. And where that all came from, that whole idea of pre-medding with atropine, that came from the old days when people were using a lot of sucks, and we talked about that reflex bradycardia that kids get in response to sucks. That idea of pre-medicating them came from that. And now using other paralytics, we don't really see that as much. It's not proven really effective. And really, in order to pre-medicate somebody, you have to give the atropine a couple of minutes before you intubate them. We generally don't have that kind of time when we're intubating people. We're generally doing more emergent airways. And so sometimes you will have that time, especially if you're taking steps and optimizing your patient. But we really don't do it. I haven't pre-medicated for an intubation, I mean, since I was like an intern probably.
I kind of see the point to it though, because isn't part of the bradycardia hypotension from manipulating the baroreceptors in the neck?
Yeah.
Atropine directly blocks that parasympathetic response, right?
Theoretically, yes. But large scale studies looking at thousands of kids getting intubated, and there was no statistically significant decrease in bradycardia related to atropine administration. So theoretically, yes, but it doesn't seem to really do it, I guess is what I'm saying. All right. Again, this is probably the most key point about breathing. An intact airway does not necessarily mean you're ventilating well, okay? So, and good sats don't always necessarily mean you're ventilating well, okay? Sats are related to oxygenation, not ventilation. So even if this kid has an intact airway and is breathing, and you slap the non-rebreather on them and flood them with oxygen, and their sats are 93, 94 in the range we go, good enough, boo-boo. Look at their breathing, because that doesn't necessarily mean they're ventilating, meaning exchanging gas well, right? Because if they're breathing 8 times a minute with shallow respirations, we may be maintaining their sats, and if I draw blood gas on them, their PO2 may look great, but that doesn't mean that they're actually exchanging gas and ventilating adequately, right? And so their PCO2 on that blood gas could be 75, 100, 110, right? So where can we check that? With capnography. Capnography, nasal cannula, however you want to do it. They make the ones that have the little mouthpieces too. Capnography will give us that information. Also, you can get that information generally pretty easily by looking at them, right? So if their respirations look terrible, they're retracting and they're only breathing 8 times a minute, chances are even if they're oxygenating well and have an intact airway, they still may need ventilation, right? So bagging them and assisting their respirations, okay? So again, intact airway does not always equal ventilation. Signs of respiratory distress in kids, again, thinking about the B side of our assessment triangle for children, tachypnea, stridor, grunting, nasal flaring, all the things we kind of look at when we look at kids and we think about signs of increased work of breathing. Blunt chest wall and pulmonary trauma is common. Again, they have more compliant chest walls. We touched on this earlier. Their bones are soft. Their chest walls are compliant. And so they can have significant underlying injury without a lot of overlying signs, right? There may just be a little bruising. They're not going to get the big obvious flail segment or crepitus from 4 broken ribs that we typically think of looking for in adults when we're looking for underlying pulmonary or cardiac injury, okay? Again, flail chest may occur. It is much less rare though, and with less ribs involved in adults. So typically you get a flail segment in adults, you get 4 or 5 kind of chunked out ribs. Kids can get it with just 2. But again, really rare. Major vascular injury is uncommon. The one beautiful thing about being a kid is that is both a positive and negative. So we talked about things aren't as fixed in their mediastinum as in adults. So adults that get trauma and get those big vascular tears from all that shearing force, kids just kind of slide around a little bit. And so major vascular injury is a lot less common in kids than it is in adults. Pulmonary contusion, pneumothorax, hemothorax, and rib fractures are the most common kind of chest and lung injuries. And again, can occur without all those overlying signs. I have no idea what, there we go, okay. So again, looking at this, obviously this chest x-ray, this is bad, right? Because you can see the airway is shifted, the mediastinum, the cardiac shadow is shifted, big old pneumothorax, right? Bunch of air in that chest. Looking at this person with a hemothorax, big old whited out side of their chest. So a bunch of blood filling that chest. All right, circulation. So circulation, And again, we're talking about trauma. So thinking about circulation is not just circulation of the patient, but circulation as being also hemorrhage control, right? Because air goes in and out, blood goes round and round. But if the blood isn't going round and round because it's spurting out, we're not doing a lot of good, right? So circulation, not just assessing and helping circulation, but also circulation being hemorrhage control, a major part of that. So heart rate, pulses, perfusion, again, we're thinking assessment. So we're thinking about that C part of the circulation part of our pediatric assessment triangle, all the things we would normally look at in a kid: heart rate, pulses, perfusion. Capillary refill is excellent in kids. Kids don't have as many ways to compensate for blood loss and for shock as adults do. And one of the big things they rely on is their increased peripheral vascular resistance and their ability to shunt blood. And so while I sort of poo-pooed capillary refill when I was taking care of adults more, it is actually incredibly useful for kids. You can squeeze their foot, and if it's over 4 seconds, you can reliably say the kid is shunting blood and probably approaching some form of shock, okay? Their color, are they pale? Are they cyanotic? How are they acting? Their sensorium, is this kid out of it? Or are they really, really fussy that makes us think they have some painful underlying injury, or progressing into shock? As kids progress in shock, they'll initially get really fussy and then they move to the sleepy side of things. So altered vital signs, tachycardia. The most important sign of shock in a child is tachycardia. Most people, because I've given it probably twice for EMS challenge, at least I know of, have seen my assessment of kids in shock talk, okay? Shock, the most common sign and earliest sign of hypotension or of shock in a child is tachycardia, okay? And we're going to talk about why in a second. But tachycardia is the most important and under-recognized sign of shock in children. Kids can be in shock despite having a normal blood pressure, okay? So the idea that shock equals high heart rate, low blood pressure that's been branded into you since day one of EMT school was a lie when it comes to kids. Kids can be in shock and in profound shock despite a normal blood pressure. And it's because they are so good at compensating using the couple of mechanisms they have. The problem is everybody's heard the notion that kids do great until they fall off the cliff. And that's because once they have fewer mechanisms to compensate. And once they max those out, things go downhill fast because they've compensated so well for so long, okay? Again, physical findings, delayed cap refill, cool pale extremities, alter mental status, things we sort of already touched on. Again, children are adept at compensating for blood loss. They're good at compensating for shock. They just have fewer ways to do it. And once they max those out, things go downhill quick. Tachycardia is an early sign. Depressed mental status can be a great sign too. And then perfusion and cap refill. Again, hypotension is an incredibly late sign of shock, okay? So if we look at this chart, the green line is your heart rate. This is percent normal on the y-axis and percent blood loss on the x-axis, okay? The top green line is heart rate. The black middle line is blood pressure. And the red bottom line, or orange, whatever color that's supposed to be, bottom line is cardiac output, okay? So if you are in shock, that means you are not getting blood where it needs to go, right? We can talk about inadequate in-tissue perfusion and multi-organ perfusion and whatever, but the real simple version is you're not getting blood where it needs to go, right? And so if you're not getting blood where you need to go, you got to move blood, okay? And you can do this by increasing your peripheral vascular resistance and shunting blood, which kids are highly adept at, increasing how well your heart beats, right? So pushing out more blood with each beat, right? And thinking about cardiac and thinking about the Starling curve that people learned in paramedic school and then promptly tried to forget. And then you can also make your heart beat faster, okay? The problem with kids is their hearts already beat incredibly efficient, okay? And so their ability to pump blood better, meaning more with each beat, is incredibly low. They can't really shift very far that way. So their way they compensated by jacking their heart rate up. And they can do that because they have all healthy hearts, right? So kids, right, babies who are just febrile even and don't feel good. So a 4-month-old, they can jack their heart rate up to like 190 and it doesn't even bother them, right? So kids will jack their heart rate up. It is their biggest compensatory mechanism for shock, okay? And so what you're seeing here is that heart rate is going up, 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 up. Their cardiac output is still starting to drop a little bit, right? Because they're going further and further into shock, but they're really kind of maintaining. But because they can keep that heart rate up, their blood pressure is being unchanged, right? So here we are at 30% blood loss, heart rate's way up, cardiac output's down a little bit, but blood pressure is still really normal, right? Despite the fact a third of their blood is outside their body, or maybe sitting in their abdomen, or wherever it's going, okay? And so, but then what happens? Well, you can't really get your heart rate up much farther. You've maxed that out. That blood pressure starts to fall. Cardiac output starts to drastically drop off. And then what happens to your heart rate out here? What's this? This is your patient arresting, right? Because now they've really stopped compensating completely in their coding. And look how small. So you can lose 30% blood loss and still maintain a normal blood pressure and essentially normal cardiac output. But then you only have from 30 to 45 until you start to go into cardiac arrest. And so that progression occurs very, very quickly. And so if you see a kid who's hypotensive, you're already way behind the 8 ball because you're right here. You are not in a good place to live, okay? And so be sensitive to the signs that occur out here so that you can correct it before you get here.
I think it's also helpful to note that the patient's heart rate goes through the normal range as they're severely.
Yeah, as they start to code. Yeah. And so things like being a little sleepy, delayed cap refill, and tachycardia should clue you in that your patient's in shock no matter what their blood pressure is. And you need to start resuscitating that kid, because if you don't, you're going to quickly find yourself in this neighborhood. And that's the neighborhood you don't want to live in. Okay? So be sensitive to those signs of shock. Control hemorrhage quickly. Be sensitive to those signs of tachycardia and delayed cap refill. Things that we normally go, heart rate's a little up, and then we sort of kind of half check cap refill so we can check the box on the PCR. Those are things that will keep you and your patient alive and happy, okay? So again, why are they in shock? Hemorrhage is responsible for 20 to 40% of all pediatric trauma deaths. All right, so this became a lot easier part of this talk to give now that Stop the Bleed campaign came about, because now everybody is really sensitive to hemorrhage control and doing things like direct pressure, quickly progressing to tourniquet usage, all the things that we do, okay? So step one is stop the bleeding. Remember that the blood volume of a child, though, is only about 70 to 90 mLs per kilo, okay? And full-term toddlers are in that 80 range, okay? So the idea with that is, remember that blood loss is relative. So if you take a pint of blood out of me, no big deal, right? I can go down the street to the Red Cross and give a pint of blood. They give me my orange juice and my cookie, and I walk out just fine, right? But if this is a 4-month-old who only has 70 mLs per kilo of blood volume, that pint becomes a much bigger deal for them, right? Because now we're talking about looking at more, we're in that 20 to 30% range where we need to be getting nervous because things are going to go downhill quick. So remember that even though they may have smaller amounts of blood around them, or that big distended belly that lets you know there's blood in their belly, even though it might be a smaller volume, that may still be a big deal for them because they have a smaller circulating blood volume, okay? So again, what appears to be a small amount can add up quickly. Again, 200 mLs in a 10-kilo 1-year-old or a toddler, that is 25% of their whole circulating blood volume. Do you think that kid's in shock? Absolutely. Do we need to resuscitate them? 100%. So we need to control that bleeding, and we need to start resuscitating that patient. Again, other sources of shock, things we don't always think about where kids can lose a lot of blood. Chest, again, they are really prone to developing a tension pneumothorax if they drop a lung. So they may have an obstructive shock from a tension pneumo. And how we can fix those. We can needle people, right? Don't call me for orders for a needle. We quit doing that a long time ago. If you need to needle a patient, please just decompress their pneumo, all right? Fix the problem that's going to imminently kill them, all right? So if it's a little kid, I will decompress chest with a 20 or an 18. We don't go for the 2-inch 14 gauge in the little, 8-kilo, 8-month-old, okay? So remember, size is relative when it comes to procedure equipment too, okay? So it's okay to use a smaller 18 or 20 gauge. Make sure you're getting through all that sub-Q layer. You'll feel the change in resistance, okay? And then you should hear, hopefully, although probably not because you're probably in the back of a noisy ambulance, that nice gush of air when you pull the needle out. Okay, I had one kid, I put it in, I wasn't holding the needle well, I was holding like the hub of the angiocath and the needle like shot out the top. That was a real good sign that I had decompressed them pretty well. And then remember to stop cock it afterwards, just like we do with adults. Hemothorax, kids can lose a fair amount of blood into their chest. I showed you that x-ray with that whole whited out side. Remember, kids have really compliant chest walls, and so they can actually lose a fair amount of blood into their chest. Their pelvis. So kids can lose a lot of blood in their pelvis. Pelvic fractures are not super common in kids, but kids, it's still a very active site of bone marrow, of like creating blood cells and stuff like that in kids, and they'll lose a lot of blood. It's highly vascularized in kids, okay? Same thing with long bone fractures, especially their femur. Kids, especially little babies, can fracture their femur a little easier than most adults. And especially if their car seat wasn't secured right and they're sitting like this in their car seat, get kind of squished, right? So if they have a big old, like our kid we talked about in our case, had that big old thigh deformity, those kids can lose a lot of blood in there. That's a really expandable cavity for them. Their abdomen, little kids and babies, what do they all have? Big old Buddha bellies, right? Their belly is like 80% of their torso, okay? And so if they get a liver lac or they get a splenic lac, they can put a lot of blood into their bellies. So look at the patient. Are they bleeding? Remember, we do our little blood sweep and look at everything. Control any external hemorrhage and be sensitive to the places they could be losing blood internally, because knowing their injuries can also help you gauge your resuscitation. Again, early vascular access is important. At least one, if not two, peripheral IVs for the really shocky kid, and then intraosseous lines early, okay? We see a lot of people who come in who have been afraid to IO these shocky, sick kids, where if you had IO'd them and started resuscitating them, they probably would look better, or at least be more stable. So do not be afraid to IO these kids. It is a Category A procedure for shock and for cardiac arrest, okay? So remember, vascular access is key to resuscitating these kids. Don't be afraid to place an IO line in a shocky, sick trauma patient, okay? Because you have to resuscitate them somehow. And remember, we talked about these kids are great at increasing the peripheral vascular resistance and shunting blood. And so getting a line in these kids can be really, really hard when they're already shocky and you're behind that 8 ball and they're shunting blood and they're in some kind of state of collapse even potentially, okay? Yeah.
So we had somebody ask, do many services departments carry ped-sized tourniquets? And I have to admit, I've never actually thought of that before. So do the regular cat tourniquets work on a kid? Yeah, so they'll get small enough to work on a kid.
If it's an infant, like a 4-month-old, probably not. Honestly, though, at that point, you can probably jerry-rig a tourniquet out of stuff you've got because everything is so small and easy to just sort of tie tight. But for most kids, the cat tourniquets will go down small enough.
It's probably not going to take as much pressure with a little small child on them,
Correct.
I would think.
Correct.
So like a blood pressure cuff.
Absolutely.
Blood pressure cuff. Okay, thanks.
Yeah. All right, remember crystalloid challenge, 20 mLs per kilo. If an inadequate response, repeat it 20. We can do 40. Remember, we've sort of shifted in trauma, right? So when I went through paramedic school, and when Wes probably went through paramedic school, we would 2 wide open IVs and we dump like 4 or 5 liters into these patients by the time we hit the trauma bay, minimum, right? And in fact, if you got less than 2 in, you felt like you had messed up somehow. And so now we're going, that probably wasn't the best idea, because it turns out all we're doing is taking blood and making Kool-Aid, All right. And we're also worsening the coagulopathy. We're worsening their acidosis. We're worsening, we're breaking loose clots that we probably shouldn't have. All kinds of reasons. So we talk a lot about how much fluid to give kids, 20, 40, 60 per kilo. When do we start pressors? When do we start thinking about other stuff? Right now, we sort of stand at 20 to 40 per kilo. If you don't like your response, there's no point in giving more. Okay. At that point, we need to talk about blood if you're an agency that carries blood, which there's a few of, or we need to talk about pressors, okay? Whether it's an epi-drip or whatever it is. Thank God somebody's turning down the AC. Praise Jesus. I'm dying up here, and I'm out of Diet Coke. So 20 per kilo is reasonable. If we don't like our response, we can try another 20. If we don't like it at that point, we really, really need to start thinking about doing other stuff, okay? Because at that point, we're probably not going to get the response. And remember, kids who are prone to head and spine injuries, we can dump as much fluid in them as we want. If they're in neurogenic shock, what we really need is pressors, okay? Whether that's epi, phenylephrine, levofed, whatever we carry that we like and want to use. Dopamine typically doesn't work stellar for neurogenic shock. Epi would be your better alternative. And everybody has epi. You may not have a pre-mixed bag of epi, but you have epi, okay? And that's where push dose pressors can become incredibly easy and useful. So I mentioned push dose pressors. I don't want to digress on a whole talk of push dose pressors, but to talk about them real quick, this is when you draw up a small amount of epi. If it's an adult, say, you draw up 1 ml of epi, you squirt, and then 10 mLs of normal saline. Or the easier way is you squirt out an ml from your flush, draw up 1 ml, shake it up, and then you push an ml at a time, okay? This works incredibly well because in EMS, we're not really great at doing drips. We don't have pumps. You have to stand there and count. You're doing math of a micro drop set versus a macro drop set, okay? With 7 or whatever, however many 0.7 mics per kilo or whatever dose you're giving, okay? And it becomes incredibly difficult. It's not a skill we're used to. We're really good at pushing meds. That is a skill we are good at and practiced at. So the idea is that you basically become the drip. You push a small amount of pressor at a time that simulates sort of creating a drip, but in a skill that we are much better and more practiced at, okay? We do this in kids in my ER all the time. There's 2 schools of thought on how to do this, okay? One is to do the 1 ml just like you do for adults. That way it's a known standard concentration and you just push less. Yes, of 1 to 10,000. And you just push less, okay? So do like a half an ml. The other, and what I do in my ER when I'm desperate and need to get somebody's pressure up quick, is I take a code dose of epi, the kid's code dose of epi, so 0.01 mg per kg, and I dilute that into the 10 mLs or 9 mLs, whatever, okay? And then I can still push 1 ml at a time because I've diluted down the concentration to be more appropriate to the size of the kid, all right? 2 schools of thought, either one works, both are just fine. One saves you a little math, and that may be worthwhile, but they're effective, okay? You just got to be careful because if you give that kid a whole ml or 2 mLs because you're pushing hard or you hit a bump in the ambulance, what you don't want to do is then jack that kid's pressure up to 200 over something and blow loose whatever clot they've formed, okay? So it's effective, but you have to be very, very careful when doing them. Okay, and this is a whole different talk for a different day, but
we've got a question that may be related there. Somebody asked, can you do a brief description of the Frank-Starling curve? And they add, if it's rabbit hole, don't worry about it.
That is way too rabbit hole.
Okay.
Way too rabbit hole. That's like a whole separate hour talk right there. Plus, I'd have to try and remember most of the Frank-Starling curve, which I've tried to forget over my last 15 years of my career. All right, so if you're carrying blood, start blood after 20 to 40. If you're not, start thinking about pressors, especially if there's concern for neurogenic shock. Disability, neurologic status, rapid, brief neuroassessment. Remember spinal precautions. There used to be this notion that kids did not fracture their cervical or did not get cervical spine injuries like adults do. The answer is that they do, they just get them differently. And we'll talk about that more in just a second. But spinal cautions are still paramount. I can't tell you how many toddlers I see come in who have zero spinal precautions in place, okay? I understand that cervical collars don't always go down small enough. If you don't have one small enough, you can pack them in a certain way, okay? But it's really important to really still control their cervical spine. Their GCS. Assessing a GCS is difficult, but not impossible, okay? I know it's a pain, but it really gives people a good idea of their neurologic status, okay? It is different for kids than adults. So please don't tell me that the, 5-year-old or the 8-month-old has a GCS of 6 because they aren't following commands, okay? They're not going to follow commands. There is a different scale for kids, okay? And then level of consciousness and assessing pupils. Assume all trauma patients have a C-spine injury, backboard them. We don't really do anymore. Sometimes it is easier to use to transport them, though, and to get them out of wherever it is they're stuck, trapped, fell from. So if you have to use one, it's okay. I'm not going to get mad that they're on one, but try and get them off if you can, or just let us know that's why they're on there. I get that they can still be really useful in the right situation, okay? Again, this is an x-ray of a kid's cervical spine, and this is why kids get different cervical spine injuries. So if you look at these vertebral bodies, they're really wedged anteriorly, kind of shaped like this, not big and flat like an adult's are, okay? And their spinal ligaments, their anterior and posterior spinal ligaments that hold those vertebral bodies in place are still really flexible. They're not really fibrous and formed yet, okay? And so what you've done is taken this big bobblehead and put it on top of essentially an unstable structure. Okay, so if you think about engineering, something that's stacked but shaped like this with unstable things holding it in place, not really the best structure in the world, okay? And so adults tend to fracture their cervical spine. Kids don't fracture, they sublux. So that anterior wedge vertebrae kind of slips, okay? And so cervical spine injury in kids is not super common, but it is not unheard of. It is not, there used to be this notion that kids just didn't get cervical spine injuries, and we didn't need to worry about C-spine in kids. And that's not true. They just get different injuries than adults do, okay? Cervical spine injuries in younger kids tend to be uncommon. Older children tend to have distribution similar to adults. Children are more likely to have cervical cord and spinal cord injuries without fracture. Again, that's from subluxation. And the properties of pediatric spines sort of predispose them to injury, and we just sort of talked about that looking at that x-ray picture. Again, head injury is the leading cause of mortality and long-term morbidity in peds patients. Falls, MVAs, ATVs, I'm pretty sure ATV needs to move like up here in Alabama, but falls, ATVs, vehicle collisions, bicycles, all kinds of things. They're different from adults because their brain is different, right? So they contain more water than mature adult brains, so they're less compliant, right? So if they get a big bleed, they don't sort of squish around as well, so to speak. They have a higher rate. They are way more dependent because they're developing brains, they're developing neurons. They are very dependent on having a really, really good blood flow. And they have a high rate of apoptosis. Those cells start to die really quickly, okay? And so it's together, they explain kind of the higher morbidity and mortality that we tend to see from TBI in kids as opposed to adults, okay? And again, this is where managing them becomes so important. We know hypoxia makes your TBI worse. We know hypotension makes your TBI worse, right? Because your cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure, right? So if you already have a high ICP from your head injury because you've got blood now occupying that fixed space, and your MAP, your mean arterial pressure, is in the tank, then your cerebral perfusion pressure is awful, okay? So we've got to address that hypotension. We've got to address that hypoxia to prevent cell death. All those things we've talked about, those ABCs are so important to address as we're managing these TBI patients.
So kind of related to that, it's a little bit of a stretch, but this is a question that came in directly to me. from somebody watching. Why is TXA contraindicated in pediatric patients?
Because we never studied it in kids yet. So PCARN, which is the Pediatric Emergency Care and Research Network, which did the big head injury study, the big sepsis and baby study, a lot of things have sort of revolutionized what we've done in peds in the last probably 10 years. They are currently doing a large randomized multi-center trial of TXA as we speak. We don't have results yet. It is contraindicated because we honestly don't know what it does or if it works. It has never been studied. The only studies we have in kids were a few case reports and studies largely from the battlefield of kids who were incidentally involved in battles and got either blast injuries mainly, like were near an IED when it went off and had head injuries and got TXA from the Army, like the military field medics who use a lot of TXA. And there is potentially, the problem is they showed that it improved their mortality. They did not show whether or not, they didn't have enough studies to know whether or not it changed their morbidity and they never looked at any potential side effects. And so the answer is it's contraindicated because we don't know in kids. And we are very hesitant to just start giving stuff, especially knowing the difference in the way kids clot and the difference in their physiology. There's some potential negatives there that we don't really want to aggravate or give if we don't know it makes a difference. Because if you think about the TXA, like the impact studies, really, if you remember and you look at those studies, they had to change their study endpoint in order to get statistical significance. And so it works in adults, probably, right? We talked about this at EMS conference and some of the problems that we saw with those studies. And so we started using it a lot, but we don't know what it does in kids. And so we aren't giving it right now.
Fair enough. I think the general prompt for the question is good, though. If the kid has a head injury and is bleeding elsewhere, we know we have to prevent hypoxia, then stopping the bleeding becomes even that much more important.
Yeah, it does. And I get the desire to say, hey, we have this drug, we know it works, we want to give it. Well, we know it works in adults. We do not know that it does anything in kids. And there are some truly potential bad side effects that we don't know in kids. And so until we have something that says the benefit outweighs the risk, then I would definitely not do it. In fact, we don't even keep it in our trauma bay because our trauma surgeons are so anti right now until we get some data on it. Just as an aside. All right. Treatment of head injuries, avoid hypoxia and hypotension. Remember, we already talked about that. Control their airway. We talked about that. If they're in the ER, we're going to put a bolt in their head, okay? Or in the trauma bay, we're probably going to put in an ICP monitor. And then remember, CPP is MAP minus ICP. So if you're not maintaining this number is going to be terrible, okay? This one you can't really control. You can't do a burr hole on 65, okay? This number you can control though, okay? And then treat all their injuries that may contribute to hypoxia or hypotension. So stopping blood loss, needling the chest if you have to. Other things that will contribute to this that will help you improve that. Okay? The other thing that people always ask about is whether or not to hyperventilate these kids. Okay? Hyperventilation is useful as an acute, temporary, short-term measure to help control imminent herniation. You should not, at baseline, hyperventilate these head injuries. Okay? Because eventually what happens is you hyperventilate them enough that they tank out their CO2, and then they start to get vasoconstriction, and then their ICP starts to get crappy again, or their CPP starts to get crappy again. So it used to be, again, back in the day, we always ventilated head injuries at a rate of like 30 to 40, like crazy hyperventilated all these people because we thought we were making a difference. It's useful temporarily, so if the kid is imminently herniating and trying to die, yeah, we'll hyperventilate them because it'll acutely bring that down, ICP down, okay? But it is not a good thing to do over the long term. And if you look at, where did they do that big study on head injury? Was it somewhere in Texas? They did a big thing. They did a big head study injury, and they looked, and one of the things they identified that drastically reduced their morbidity and mortality was maintaining normal ventilations, i.e. not letting them get hypoxic, but not hyperventilating them. treating ICP. So if you have a kid who's imminently herniating, you can sedate and paralyze them. That'll drop their ICP. Hypertonic saline works really well, and we have used a lot of it in these head injuries in kids. So people talk about two drugs when you're talking about like herniating and trying to quickly drop ICP. And one of those is, the two are hypertonic saline and mannitol, right? Mannitol will do the job. I promise you. It works really well. The problem is, what kind of drug is mannitol? It's actually a diuretic, right? And so kids who have smaller circulating fluid volumes and blood volumes and are really preload dependent for a lot of reasons, we don't love giving them mannitol unless it's our only option and we're just stuck. We can do it, but we have to be able to compensate for it, okay? So we use a lot of hypertonic saline, okay, because it works really well. Give them like 5 mLs per kilo of hypertonic saline, fast push it, jacks up their sodium, drops their ICP, and does it in a way that doesn't essentially diurese them, okay, and continue to affect their preload and hemodynamics. So we still use mannitol. We have gotten away from using it and more towards giving hypertonic saline in kids for a lot of, that's one of the reasons. There's a lot of reasons, but that's probably the biggest, okay? So giving them hypertonic saline. And then obviously these we can't really do in the field, unfortunately. These we potentially can, okay? And then exposure, making sure completely undressing your patients. You never know what you're going to find sometimes. Looking at pediatric injury patterns. So Waddell's triad of injuries. The kid who gets hit by the car, they get the femur fracture, the chest injury, and then the secondary head injury because of their size and how they're hit. The typical pediatric handlebar injury. So they have two injuries. Everybody notices the head injury. What they forget about is the big blunt abdominal injury, right? Because as they go up over the handlebars, they tend to hit their abdomen. All right, so back to our case. That's our kid's vitals. Here's their exam. What are we worried about? Well, look, first off, let's look at that heart rate. Does that look good? Does that look good? So remember, we talked about this was an 18-month-old, right? Or 20-month, something 1 or 2-year-old. So is that actually a hypotensive, normotensive, or hypertensive for a kid that age? Hypertensive. And their rate? They're not breathing great. So they are bradycardic, hypertensive, with low respirations. What do we call that? Yeah, we call that Cushing's triad. And again, the point of that picking these numbers was to demonstrate most of the time we look at that number and go, all right, because we're used to seeing people who are hypertensive at baseline anyway and live in the 130s anyway, right? Or they're hurting. And so we look at that number and go, we're doing good, guys, we're doing good, all right? And we kind of forget that kids should have a heart rate of more like 100 sometimes. And so we kind of look at these and go and kind of forget, and we think through our adult looking lenses and we go, all right, not too bad. But the reality is this is really bad. This is a kid with significant head injury who's probably either herniating or trying to herniate and fixing to die, okay? So, and then we have all these injuries. We got facial injuries, and that can complicate our airway management, right? We have the left chest with no obvious crepitus, and look at those SATs. So those SATs could be related to those low respirations, but again, we talked about kids can have underlying chest injury without a lot of outward signs. So maybe we have a pneumo, a hemo-pneumo, maybe we have just a big pulmonary contusion that's affecting our ability to oxygenate, right? And then we have deformity of the left thigh, and we know we kids can dump a lot of blood in there. And if we're hypertensive from our head injury, what's going to happen to that blood loss in our thigh? It's just going to keep getting worse, right? And then we have abrasions everywhere. So we got a lot of injuries we need to address. But what is the most important thing we need to address? A, B, C, D, E. We've got to start doing BLS airway. We've got to ventilate this kid. We've got to get access. We've got to start resuscitating. And then we've got to definitively control our airway in one way or another. Okay? And then where do we take this kid? We take this kid to a trauma center. All right? This doesn't go to community ER that's like down the road. This kid goes to a trauma center. Every day, all day, this kid goes to a trauma center. We're talking more about transport decisions when we talk about pediatric arrest. All right, we're gonna skip over burns today. All right, guys, any questions?
I think we covered all the questions so far. Pretty interactive group today. Y'all keep the questions and comments coming. We're even getting some answers to questions on the chat, which is great, in the form of videos and references.
Yay.
So the next section, you want to take a couple minutes break?
Mm-hmm.
All right, we're going to take a couple minutes break, everybody, and we're going to come back and talk about pediatric cardiac arrest.
Didn't feel better for you?
Yeah, thanks.
It was getting stuck in here.
Yeah. Do what? Oh.
That was great.
Yeah.
Everybody, welcome back. We're going to go ahead and keep going. Got Dr. Shea Duerring here from Children's Hospital today, and our next topic is pediatric out-of-hospital cardiac arrest. So take it away, Dr. Duerring.
All right, guys. So we're going to talk about some new stuff with peds cardiac arrest. This is not going to be a review of PALS. All right. And Wes is going to have a little bit of a seizure, and it's okay. We'll give him some Versed back there. But we're gonna talk about some new stuff and some new ideas, because the whole point of EMS Challenge is to learn new things and to challenge people. Okay. So that's what we're going to do today. So we're going to step out of our comfort zones for a little bit. So we got a 4-year-old otherwise healthy male-term infant, call is for unresponsive. Mom and dad walked in, fed him at 5 a.m., went back around 6 a.m., found him unresponsive in the crib. You get there, he's blue, he's cyanotic, he's pulseless, he's apneic. This is not an uncommon story, and it's the story that makes every single provider go whoop and start paying attention, okay? So who's excited about this call? Nobody, right? This is not the call you want. And it's always at 5, 6 in the morning. So it's in the back end of your 24 when you're not your freshest, which always makes it that much better. All right. So how common is this? What's survival like? We talk a lot about PALS and like flow sheets for cardiac arrest, but we don't talk about survival rates, survival to meaningful with good neurologic recovery, right? We don't talk about how common it truly is a lot. What interventions do we really need to do, right? What are our common pitfalls? Where do we take this patient? There's a lot of things that go into cardiac arrest for kids that we don't always talk about because we get so caught up in BLS, CPR, and PALS, right? But stuff that really affects what we do. And that's the stuff we're going to talk about today. So in the United States, approximately 16,000 pediatric patients suffer cardiac arrest each year, which is a lot higher than what most people anticipate. This is more common than what we realize, okay? There's a ton of studies looking at outcome and management of adults for out-of-hospital cardiac arrest. You can Google adult out-of-hospital cardiac arrest, and you will get 15 pages of results, minimum. And that's in the last probably 10 years. You Google pediatric out-of-hospital cardiac arrest, you won't get a full one, okay? Unless you just get a bunch of adult studies that come back with it, because that's usually what happens. There are not a lot of studies looking at pediatric out-of-hospital cardiac arrest management and EMS. There are a handful that look at it with a reported survival rate of anywhere from 2 to 24%, because that's a helpful number. You either probably don't live or you got a quarter of a chance of living. Not useful. Because again, there's not a lot of studies and they're sort of all over the place. There are some newer studies. This is sort of historically looking at it. There are some newer studies that give us some more insights though. There was a study done that used CARES data from 2005 to 2013 and examined the characteristics of 1,980 pediatric out-of-hospital cardiac arrest. The vast majority were infants and young children, which isn't surprising, okay? And then older children and teenagers, smaller amount, okay? About 59% were male, 13% were African American, 26% were Caucasian, and the rest were either unknown, not identified, or other smaller percentages, okay? But again, these are the kids, this is the vast majority of what we do when we talk about pediatric out-of-hospital cardiac arrest. Young kids and infants, so kids under the age of like 7, little kids. Looking at the rhythm in those kids, 1,778, 90% had a non-shockable rhythm of asystole or PEA identified as their initial rhythm. Not surprising. We know that VFib and VTAC arrests in kids that are otherwise healthy with underlying congenital cardiac disease is pretty rare. Teenagers were more likely to have shockable rhythms than infants and younger kids. Again, not surprising. We know teenagers tend to act more like adults, okay? And so mostly non-shockable. Survival. Only 162 survived to hospital discharge. So only 8.2%. That is abysmal. 8.2% survival to hospital discharge.
Hey, just for comparison, that number is closer to 10% for adults in the CARES data.
Yeah, we're going to talk about that too.
Yeah, and it's kind of useful to point out that this is best case scenario because I think it's reasonable to assume that only the leading EMS agencies enter data into the cardiac registry.
So this is 8.2% of agencies who voluntarily track their own cardiac arrest data and pay in to use the CARES database. So you're probably getting a selection bias from the data because your data is from people who care and who are trying to do better. So using CARES data is great, but you're also getting a little bit of bias in that data because you're getting agencies that are actively trying to look at their own numbers and make them better. And so the reality is, if we know it's 8.2 from CARES data, we're probably still a little closer to the 2% side of this number as a general rule, okay? And then teenagers were more likely to survive than infants and young infants. That's probably related to the fact that teenagers are more like adults. People are more comfortable managing them. They tend to present with shockable rhythms. A lot of reasons that go into that, but they have an increased survival. Similar to those with adult witness arrest, bystander CPR actually positively contributed as well. More recent CARES data. So remember that stopped in like 2010 or something like that, 2013. Looking at more recent CARES data, analysis suggests our current survival rate is somewhere from 5 to 10%. So maybe moved up from the 8 a little bit. Maybe, again, a little bit of a selection bias there. With good neurologic outcomes ranging from either 0 to 30%, depending on what year and what you might make your cutoff for good, okay? So even if we're surviving, we're not really having good outcome. And why is that? Compare this to adults. There have been a ton of studies looking at optimization of out-of-hospital cardiac arrest management of adults in the last 10 to 15 years and what we can do better. They've optimized care. They've looked at goal-directed therapy, pit crew CPR, checklists of what we have to do quickly, things that we know affect survival. Survival of out-of-hospital cardiac arrest in adults is now up to 20% based on the most recent CARES data, up from 5% about 20 years ago. So we have made drastic improvements in adult out-of-hospital cardiac arrest management and care. We have made no improvements. We've essentially gone from 2 to 8 to maybe 10 in kids. So we've essentially made no improvement compared to adults. So our pediatric out-of-hospital cardiac arrest management and survival has unfortunately remained stagnant despite drastic improvements in out-of-hospital cardiac arrest care for adults. So what's made the difference? Well, they're receiving care. And this is a big problem because traditionally our management of pediatric out-of-hospital cardiac arrest has been scoop and run. And essentially we BLS these kids all the way to the ER. So that's one. Pit crew CPR approach made a huge difference looking at adults. Improvement of CPR. We know CPR is the one thing that is truly independently linked to rate of survival in cardiac arrest. The only thing that's ever been truly shown to be statistically significant. And we've improved CPR for adults, right? Because we know we're kind of bad at doing CPR in the back of an ambulance. It's been well documented in multiple studies. And so what did we do? We got mechanical CPR devices, and we started rotating compressors. We started paying more attention to our compressions. Do what?
And stay on the scene.
Yeah, and managing them again, receiving care. They're staying on scene and doing care. Most people agencies rarely transport an out-of-hospital cardiac arrest without ROSC anymore. There are situations, but it is exceedingly rare because we are bringing advanced care to the scene. We are performing it on scene with high rates of success, meeting performance measures, and we're doing what we need to do, which improves our CPR, whether it's person or machine. Most of those machines don't work for kids, by the way. They don't go down small enough. Again, that's the point. Goal-directed on-scene therapy. Early initiation of access, cardioactive meds, airway management, all things that we're doing quickly and efficiently in adults because we're staying there and we're doing them. Termination of out-of-hospital arrest in adults, right? So 30% of EMS agencies in this country do not include children in termination of out-of-hospital care. Okay, so what does that foster? That fosters the scoop and go mentality, right? Because if I can't stop resuscitation, then all I really need to do is just get them somewhere. Why should I bother starting it? So we have fostered that. We had that mentality when EMS came about in the 60s. And we still are practicing that same mentality with pediatric out-of-hospital cardiac arrest. Right? So we just talked about this. Only 30% have protocols in place that allow for termination of resuscitation in kids. This is leading to persistence of the scoop and run mentality that we are still doing. CPR quality in children and moving vehicles is poor, and we know that is the one thing that correlates to poor outcomes, right? Epi is frequently delayed, and it's frequently dosed wrong. We're going to talk more about all this stuff. Airway management has focused traditionally on intubation, and we don't know if that makes a difference. In fact, it probably hurts. And bagging of pediatric patients is poor and frequently leads to overventilation, which we know affects the quality of CPR and our coronary perfusion, right? Because how many people are using the right size bag and squeezing just till they get chest rise at that low rate of 10 to 12 that we know we still need to do for kids versus 40 and 60 times a minute of fully squeezing that bag. Okay? So compare what we do for adults, staying on scene, pit crew CPR, high quality CPR, rapid vascular access, dosing epi is easy, you push one whole syringe, right? Staying on scene and then bagging them effectively, looking for things at ROSC. Now compare that to what we do with kids. We scoop, we run, we delay drugs, we tend to dose them wrong, and we tend to mismanage their airways and misventilate them. This is why our survival rate has gone nowhere, because we are still doing things the way we did in 1964. So can we fix it? Logically, improvements made in adults could be mirrored in children, right? At this point, we can't do worse, so maybe we can do better. One group actually studied this. Polk County, Florida, 2014, their EMS crews were had limited scene treatment and were told to had scoop and run with no termination of on-scene care. In 2014, they said this sucks and we want to change it. And so they changed their training. They focused on on-scene care, quality measures, things they could do on scene. They got rid of the no termination on scene, and they got rid of the scoop and run mentality. Okay, and identified important goals for care. They then looked at their data from 2010 to 2014, so pre the change, and then 2014 to 2015, so post the change. There were no significant terms of age difference, etiology, presenting rhythm, or bystander CPR. And that's really important to understanding the importance of this study. Because if your presenting rhythm suddenly went from 0 shockable rhythms to 100 shockable rhythms, well, we know independently then your rate of survival goes up, right? But there was no significant difference in any of those. They actually didn't show a statistically significant difference in on-scene time, 14 to 17%, or 17 minutes, sorry. But their neurologically intact survival increased from 0% to 23%. So that is pre-change. They didn't have a single pediatric out-of-hospital cardiac arrest that survived to neurologically intact discharge. Afterwards, they went to 23%. They approached the same number as adults, which is unheard of in our world. So what are some goals that we can use, okay? These are not necessarily the ones they used. These are not anything other than my own musings on pediatric out-of-hospital cardiac arrest. If we want to start improving things, we have to improve our care, and that it starts with staying on scene and having goal-directed therapy. Things that we know we can do and we can improve in order to help move that number, okay? So initiation and continuation of high-quality chest compressions. This has been a cornerstone of cardiac arrest care for years now, but we're still not doing a good job with it in kids. Rapidly obtaining vascular access and drug administration, correct dosage administration, airway management, good quality ventilations, and changing in our training and mentality. And we're going to talk about each one of these goals and what we can do to be better. High-quality CPR. early studies on optimizing CPR, management of CPR and pediatric out-of-hospital cardiac arrest actually did show significantly improved survival, up to 17%. Again, we know the one thing, whether you're an adult or a kid, that independently is statistically significantly linked to your survival of out-of-hospital cardiac arrest is your quality of your CPR. It is immensely important. And there's ongoing evidence that we get pretty bad at performing CPR in the back of a moving ambulance, which isn't surprising. It's tough. You're trying not to get thrown all around. Many hospitals even now recognize poor quality CPR as a preventable harm event during in-hospital cardiac arrest care. So we should not be doing bad CPR. This is the graph that everybody's seen, right? Right, so you compress, you eventually get to a point where your coronary perfusion is pretty good. You stop compressions, it tanks, and it takes a good 1 minute of CPR almost to get that coronary perfusion pressure back up. A little less than that. Actually takes about 5 cycles, about 30 seconds. But, so, pushing hard. We've got to push hard. I don't care that these kids are little, all right? You still have to push hard like you would an adult. So at least 1/3 of the diameter of their chest, okay? We have to push fast, 100 to 120 compressions per minute, okay? So again, you're going to get tired quickly. So that means we've got to minimize interruptions and change as much as we can and change compressors. Remember, this is the biggest key and the biggest problem we see with kids. Allow the chest to fully recoil. So if you just keep pressing and that chest is never recoiling, you're minimizing the effectiveness of your compressions. So 1/3 of the diameter, 100 to 120 a minute, allowing for full recoil of that chest in between compressions, minimizing that interruption, because we want to be here where we have good continuous coronary perfusion, not here where we're consistently dropping. At that rate and that speed and that depth, you're going to tire quickly. So change your compressors every 2 minutes. This has pretty much been the standard in adults for a long time. We need to start doing it more with kids. Everybody thinks because I'm not pressing is because they're smaller, compressions are easier, and you get the one person who's been doing compressions for 20 minutes, 15 minutes, they're not being effective. That's where we're losing that hard and fast, okay? If no advanced airway, if we're going to use a BLS airway, which is perfectly reasonable, and we'll talk more about in a minute, remember to use your 15:2 compression to ventilation ratio. Vascular access. Compared to adult cohorts, kids who are critically ill, whether that's arrest, shock, trauma, whatever, are 1/3 less likely to arrive to ERs with vascular access obtained, just at baseline, okay? Again, a lot of this is related to the scoop and run mentality. Push and blow, get to the ER quick. But we've got to do better, okay? I admit that getting vascular access is difficult, but it is critically important. One study looked at pediatric out-of-hospital cardiac arrest with non-shockable rhythms, and the majority of patients received epi greater than 10 minutes after arrival of EMS. 10 minutes. Each minute of delay in epi was associated with a statistically significant decrease in survival and increase in unfavorable neurologic outcomes. So the time to access in drugs makes a difference, especially in kids who have healthy hearts in general and generally respond well to epi. Okay? So taking 10 minutes because we went in, we started bagging, we scooped, we ran, we got 5 minutes down the road and said, oh, let's look for a line because we got another 10 minutes to the ER, isn't okay. Utilize intraosseous lines early and frequently. Getting an IV in a kid is hard at baseline. Getting an IV in a kid who's in complete vascular collapse from cardiac arrest is daggone near impossible. It is a Category A procedure. It is not a hard procedure. In fact, when they studied paramedics, the average medic to place an EZ-IO line takes about 15 seconds. From time of, hey, I need to put a line in this kid, to, hey, we got a line in this kid. Okay? So there's a category A procedure. Remember our sites. We talk a lot about proximal humerus in adults for cardiac arrest. It is great if you have a kid who's big enough. Little babies, you're not going to be able to do it. Okay? Proximal tibia tends to be our go-to in kids. It's still very, very effective. I've resuscitated arrests off 2 proximal tibial IO lines. Okay? In little babies, especially if you're using the easy IO, the problem is even the pink needles, the littler needles, if they're a little like 8-week-old, 4-week-old, their little tibias, it's still easy to drill through them, right? It gets really difficult. Unless you just do a lot of them and you're really good at that change in resistance and stopping yourself, which chances are when adrenaline's running, you're working a peds arrest is not going to be the case, then that gets hard. So the distal femur is a great site in kids, and it's on the list of places you can use in Alabama. Okay? Go about 1 finger above where their kneecap should be because they don't have kneecaps. It's about 1 finger above their knee. Put it down straight down, 90 degrees straight in towards that femur, and drill down. Okay? Those black lines on the needle that we tend to ignore are actually really important because if the black line is completely buried, when you go through the skin before the bone, that needle's not going to be long enough. So if you're going to do the distal femur even in a littler baby, you may actually need the blue needle instead of the pink. You're going to have to look and gauge based on their size. But it's a lot easier to hit, and it's a lot easier to not drill straight through in those little tiny babies. Okay? So if you're working a little baby, little 2-month-old, 4-month-old, think about their distal femur. It's my favorite place to go in little babies.
Hey, Doc, a couple of questions. One, that is now in our scope of practice,
Yes.
the distal femur. 2, if you did the proximal tibia and the line didn't work, is it okay to do the distal femur?
Yep, because you're above the original site. Just like with IVs. All right, so we got our vascular access, we drilled our patient. Now we got to give them epi. Here's the problem, we frequently don't do a really good job at this. October 2006, LA County paramedics, they looked, this was when this study was published. The data they looked at from 94 to 97, 66% of doses of epi were incorrect. So we get it right less than half the time. Okay, they did a targeted QI program which focused on several aspects: Broslow tape, drug dosing charts, and early medical control contact for guidance, and that went from 66% to 35%. Okay, so by encouraging use of tools that we already have, we can drop that number and we can get this right. But at baseline, we don't do a great job of it. Another group looked at this in 2010. They did 132 paramedics where they simulated pediatric patients. One of those was cardiac arrest. 68 to 73% of the time, the epidose was incorrect. Failure to use the Broslow tape occurred in 50%. And of the 50% who used it, only 47% used it right. The red arrow goes at the head. Okay? But when's the last time people pulled out the Broslow tape and looked at it and played with it and remembered red to head and looked at the information that's on there? We tend to not sit around. We tend to sit around and talk a lot about adult cardiac arrest because we run a lot more of them. And we've had it drilled into our heads. And most agencies require you to maintain your ACLS, but not your PALS. So you probably even had a class on it in the last couple of years. Okay? But we don't tend to talk a lot about things like the Broslow tape because we think it's dumb and it's simple. But if we don't talk about it and we don't play with it, we're not going to use it right when it matters. Another group, Hoyle looked at this group in 2012. They used Michigan data, looked in January 2004 to 2006 with 8 EMS agencies looking at that cover a group of a population of 1 million people. They included patients who got any medication. They didn't even care about epi. They didn't care about cardiac arrest. They were just looking at peds med airs in general. And they looked at patients who were less than 11 years of age, seen runs and enter hospitals. They excluded people who didn't have a weight because you can't tell if the dose is right then. Error was defined as greater than 20% difference in dose from the protocol. So they even gave you a little bit of wiggle room of a weight estimation that might be a little off initially, or drawing up or rounding differences. They looked at 10,506. They had 10,506 pediatric patients. 267 only 267 who actually received meds, which tells you how low frequency getting just a med at baseline is. And 230 after ones without documentation of weight were excluded.
That means that.
So if there's a big bias here that's bad, right? Because if they excluded everything where the weight wasn't documented.
Yeah, the numbers are probably worse.
The medic didn't document the weight.
Probably didn't know the weight and didn't give the drug right. Exactly.
So all those that were excluded would probably have been increased error rates.
Correct. But just based on the fact that 267 out of all these encounters, that means that less than pediatric patients requiring medication are only 0.14% of EMS encounters. So it's a high risk, low frequency event. Factor out all the albuterol administrations and what was then Versed for seizures, and look at cardiac arrest medication administration management, you're probably looking closer to 0.04%. 43% of all drugs were dosed incorrectly. And look at the epi, 57.1% were wrong. Endotracheal tube administration, because we were not as away from that as we are now then, 100%, but they only had one administration. So if they got it wrong, it makes it look bad. But the point is, once you factor out the albuterols, the dextroses, the Benadryls, even with just looking at 1 to 10,000 epi, so IV epi in an arrest situation, 57% of the time, wrong dose for weight. So what can we do to make that better? We talked about ways to improve CPR. We talked about ways to improve vascular access. Let's improve our drug administration. This is the easiest one in the world, right? And it's on, hopefully, please God, every truck in the state, although I know it's not. Red arrow right here goes to the head. You flay this thing out, and wherever their foot falls is their weight. And if you look at it, it even gives you the doses. And for epi, which is a standard concentration, it even tells you how many mLs to push. Okay? So use your Broslow tapes. Drug dosing sheets. This is a copy of one of the ones that we use at Children's. Basically, what happens is this weight generates, we know the drugs we carry, this is the concentrations, this is the milligrams per kilogram dosing, this is the dose, and then this is the volume that gets pushed. Okay? So you could make these pretty easily, right? If you're good with Excel and you do formulas, you set each of these cells up as a formula, you change this number at the top, all of these instantly and you just print them all out. Throw them in a piece of plastic. The pediatric protocols are green, so you put them in a nice little green binder, and it sits right there on top of your PEDS bag, and then you can reduce your medication errors that way. And specifically, you can hopefully reduce your epi errors. And look at all this stuff for cardiac arrest. There's your lidocaine dose. There's your epi dose. Your dextrose dose if they're hypoglycemic, right? Thinking about H's and T's, okay? So this is another way we can minimize med errors. Phone apps. There is a ton of essentially just Broslow tape apps out there. The HandTevi app is a fancy app that people can buy, that your agency can buy, and it's really customizable, and they can put in your drug strengths, and it'll tell you what's protocol and not. It's crazy expensive, but it is definitely one of the options that are out there. Drug dosing cards, flip cards. You'll notice this is color-coded at the bottom to the Broslow color, and it has the weight in kilos and pounds, because usually parents are really good at accurately estimating weight, by the way. For kids under 8 years old, parents are right within one standard deviation of the weight 85% of the time. So, but they normally are going to give it to you in what? Pounds, right? So having pounds on there, now you just flip. And it essentially is just a flip style of the drug sheet we already showed. All right, and then people always complain that I've heard this complaint so many times. Well, I'm not going to stand around and use a binder or a card because parents are going to think I don't know what I'm doing and it looks unprofessional. Guys, these are pilots doing their pre-flight, and they're using a checklist and a binder, okay? Now it's probably on iPads, but this guy, you don't have to like him. I don't like him. He doesn't play for New England anymore either. But Tom Brady, for all intents and purposes, is a high reliability organization. He can consistently put the ball in the hand of the receiver, and his team allows his team to consistently win a Super Bowl. Whether the ball's deflated, whatever, discussion for a different day. But he is a high reliability organization, and what's he doing there? He's reading his play cards. If he can look down at his wrist and flip his play card in front of 15 million Super Bowl viewers, we can do it on scene and still maintain our professionalism and do our job well. Color-coded syringes, right? So these things are pretty slick. So you guys know the Brista jets where you pop the top, screw it together. This then slides over top of that, and you just push to whatever color they are on the Broslow tape. They come with a little, it's not shown in here, but on top of these, there's a little like tape measure and that gives you your Broslow color. All right.
I will mention, Dr. Duerring, that one thing that hinders us and pediatric drug dosing is that we're constantly getting drugs packaged differently now.
Yeah,
it's much worse now than it ever has been.
Yeah.
We sometimes have pre-filled Epi 1 to 10,000.
Yeah.
Sometimes we're mixing it on the scene. We've even got lidocaine bolus in glass vials right now.
Yeah.
On some of our units. So that does make a difference in how those systems can work.
It does. Epi, fortunately, is still pretty standardized because even if you're mixing it from the vial, you're still getting a standard concentration. So that's a little easier. Other things, it starts to change a little bit. If you're talking about other like meds, like Benadryl or something.
I guess my point is I'm all for anything that reduces the error and makes it easier during a stressful time, like drug dose charts, those vial systems, the apps. I think those are all great things. But I also think that they can lead us down a path where we forget how to do the math ourselves and we can adapt.
Well, the problem is we're pretty bad at doing the math at baseline anyway.
Right.
We're only doing it right 30% of the time. So it may lead to the point that we forget how to do it, but the point is we already forgot how to do it and we're not doing it well. So we have to rely on other systems to improve that standard.
I agree with that, yeah. Yeah, I would hope also, as part of that, we would still endeavor to do the math better.
I would hope, but airway. Historically, we have focused on endotracheal intubation for cardiac arrest management. We have always wanted to intubate arrests, okay? But pediatric endotracheal intubation has been associated with poor success rates and decreased pediatric out-of-hospital cardiac arrest survival in at least 2 studies now. That was a while ago, so maybe we got better. Well, Japan did a large nationwide study, and Japan actually utilizes pretty intense training for their medics. Their ability to intubate is ridiculous, and frequently they have physicians in the field. So their success rates, whatever. But looking at Japan, they looked at data nationwide from 2011 to 2012, looking at advanced airway management, meaning endotracheal intubation, versus a BVM with BLS airway and pediatric out-of-hospital cardiac arrest survival. There was no association between advanced airway management with increased survival nor neurologically favorable outcomes. So we now have 3 really good studies telling us that intubating our cardiac arrest kids doesn't make a difference. And in fact, maybe negatively impacts their survival rates. So BLS airways are what we've been stressing. They are quick, they are easy, they are reliable. Kids are pretty easy to bag. They have high chest wall compliances, okay? The problem is that most people are not great. We don't have a lot of people on scene, right? What's the best way to bag somebody? 2-person method. Somebody holding to maintain a good seal while somebody else is solely focused on squeezing the bag. How often do we really have enough people floating around in the back of the ambulance to make that happen? Our ability to maintain a good seal is not great. So now enter the world of supraglottic airways. They are just as quick and easy to use as most BLS airways. Eye gels don't even have a balloon you have to inflate anymore. You just shove it in. They're quick. They are effective. We don't have to worry about a seal. They secure the airway better, and they allow for easier bagging. So supraglottic airways are now category A for kids. If you have them, use them, okay? They work really well. The eye gels especially, they can go all the way down to a 2.5 kilo kid, okay? So you're talking a pretty little baby infant at 2.5 kilos, okay? It's a smaller ranges and sizes, so they're easier to size too, and there are no in balloons, no nothing. Shove it in. And they're color coded to the Broslow color within reason. There's a couple that cover 2 colors and because of the size ranges, but yes. Okay, and then you can tape them. There's this idea that you don't have to tape those, and they are pretty secure. The manufacturer actually says you're supposed to tape and secure them. Go like maxilla to maxilla and wrap it. Whatever. That's the manufacturer recommendation. Okay. All right. So we talked about airway, improving ventilation, 15 to 2 rate with basic airways, utilizing a rate of 10 to 20 with an endotracheal tube or supraglottic airway. That 12 to 20 is really key. We tend to overbag these kids. We tend to overbag them and they either drop lungs or we affect the quality of our coronary perfusion from our CPR, okay? So it is key to maintain that low rate. Count it off in your head. Use an appropriately sized bag, okay? Little bag for little people, big bag for bigger people. Remember, you don't have to fully squeeze that bag. The goal is to squeeze until you get good chest rise. So if you don't have the perfectly sized bag, that's okay. You just have to be cognizant of how you're using it. Yeah. Squeeze until you get good chest rise and then let go. Okay? Avoid overventilations. Recent studies by Vithilani and Neff show that we are really bad at bagging people, and this was adults and kids. We tend to over or under ventilate people and not get a good seal in pre-hospital arrest, both adults and kids, okay? And so we need to be better about this. And this is not hard to do. It just requires slowing down and thinking about what you're doing. Changes in training and mentality. We need to change the scoop and run mentality. We've got to get better. We have to be better. If we're going to be better, we've got to translate things we've done already, okay? This group looked at surveyed paramedics. So when you take those survey questions at the end of your national registry research that you always get annoyed with, those are actually really important. There's like a 3-year waiting list to get questions submitted to that because it's a good way to research paramedic education, okay? And paramedics' feelings on things. 43% of paramedics were aware of med errors. 60% said their training didn't include enough pediatrics. 23% hadn't had a PEDS training course in 1 to 2 years. And 27% haven't given a med in the last 12 months. So we've got to train better. We train for adult hospital cardiac arrest a lot. We need to do more training for PEDS, and we need to make that training relevant. Don't just say, I'm going to give 0.01 mg per kg of epi. Draw up that epi. Do the math. Use your chart, whatever. Make the training relevant to what you're actually doing. Not standing there running through a scenario and go, I'm going to go 0.01 mg per kg of epi. I'm going to defibrillate at 2 joules per kg. We've got to make it more relevant to what we do. More realistic. One last thing, since I'm out of time, where do we go with this patient? So part of the scoop and run mentality has always been, absolutely, we go to whatever the closest facility is. Sick patient, unstable patient, closest facility. That may not necessarily be the best thing though, especially if we're doing all the things we just talked about and doing it well. Your ability to do that is just as good as a lot of community emergency departments. And one group actually looked at this. They used the nationwide emergency department sample study, looked at children under 18 with cardiac arrest. They compared the survival to hospital discharge in patients transported to general emergency departments and pediatric specific emergency departments. The unadjusted survival rate for pediatric out of hospital cardiac arrest, 33.8% when you were taken to a pediatric ER and 18.9% taken to a general emergency department. That's an adjusted odds ratio of 2.2, meaning you are about 2 times as likely to survive if you're as a kid in a pediatric hospital cardiac arrest taken to a pediatric emergency department. We already have this mentality for other patients, right? We don't take the STEMI to the local community hospital. We take it to a STEMI center, a PCI center. We don't take a stroke to community hospital. We put them in the stroke system and we go to the stroke center. We won't take the trauma patient to the level 1 trauma center and bypass whatever hospital is maybe down the road. Pediatric out-of-hospital cardiac arrest is a specific and unique patient population that I would argue is akin to any one of those type of specialty patients. And so the mentality of scoop and run to the closest facility needs to change. We've talked about a lot of the reasons why the scoop and run mentality might need to change already. But that closest facility mentality probably needs to change too, because we can improve their survival. So if you're 5 minutes from community ER and 10 minutes from a pediatric specialty center like Children's, USA, Huntsville, places that are pediatric staff that have in-house pediatric ICUs, then that extra 5 minutes is probably worth it to go from 33.8 or from 18.9 to 33.8. Okay, so the last thing that we need to change about our mentality is also our transport decision. Now, if you're 5 minutes from general ER in the country and 45 minutes from a ped center, that's obviously a different conversation. But within reason, it is worthwhile to try and go to a pediatric emergency department. So summary, we need to change our mentality about pediatric out-of-hospital cardiac arrest. We need to get away from this notion about scoop and run. But in order to do that, we have to be able to reliably perform the things that we talked about to accomplish those goals, which means we have to improve our training. Right now, we are probably not capable necessarily everywhere of reliably performing those goals. And that is what is hindering our ability to move field care to the field and to potentially improve our pediatric out-of-hospital cardiac arrest management. So we have to change our mentality, and we have to change our training. We have to improve our training and make it more relevant. We need to focus on high-quality compressions, rapid establishment of vascular access, and rapid administration of correctly dosed epi, basically, because it's really the only drug we still use for the most part. We have to establish a BLS or supraglottic airway quickly, and we have to ventilate them appropriately and effectively, preferably with inline waveform capnography, because it gives us a lot of information about our patients. It'll give you a ton of information if you suddenly get ROSC, because all of a sudden that PCO2 goes from meh to vunk, because they started exchanging gas again, right? And then transport, when appropriate, after interventions are performed, while maintaining those interventions, and to appropriate facilities. And what that appropriate facility is may not necessarily be the closest place, depending on where you are and what your resources are. All right, guys, that's it.
Thanks, Dr. Duerring. That's a great lecture. Do have one question came in directly to me. So just to confirm, you're an advocate for staying on the scene long enough to perform those interventions we just talked about.
I am an advocate for...
How long of a time do you think that is?
I am an advocate for staying on the scene to perform appropriate interventions if we have improved our training enough to, and therefore our abilities to reliably and quickly and efficiently achieve those interventions. Looking at adult out-of-hospital cardiac arrest data, most of those interventions can occur within 10 minutes of arrival of EMS. In general, if less.
I agree.
I do not know that that translates to kids, given our current knowledge and training gap with pediatrics.
So the other thing that we found here is that our average time to ROSC is much longer on the scene than we originally thought it would be.
Yeah.
So I would say that we're probably 30 minutes on the scene average on a successful resuscitation.
And I would say it is still important to transport these kids because there's other things that can happen like ECMO and other stuff that can contribute to survival at the hospital. And so I still think transport is important, whether or not we've necessarily got ROS. But I would advocate for staying on scene, reliably, efficiently performing, assuming we can reliably and efficiently perform those goals of care. And then once we have achieved those interventions and that goal of care, of then initiating transport while maintaining those interventions as best we can.
So just to drill down that a little bit, the goals of care you're talking about are successfully ventilating the child, whether it's with an advanced or a BLS airway, would be one, successfully performing chest compressions, and successfully gaining vascular access and giving at least the first epinephrine dose.
Correct.
Yeah, so that maybe we could start with a training standard there and do some training and see how long it takes our folks to do that in a simulated situation and see if everybody's comfortable. Because I think, I'm maybe speaking out of turn, but I think a lot of EMS providers have the feeling that if we're on the scene with a baby in cardiac arrest for 20 minutes to get that done, that we're going to get a lot of blowback from not only family members on the scene, but also physicians and other staff members at the hospital. So it's
again, though, if we look at that data from Polk County, their scene times actually didn't increase that much. So 14.3 minutes to 17.6 minutes.
right.
Now, again, they did a lot of targeted training that allowed that efficiency. But again, that goes back to, we can do this if we're willing to put in the training and the time in order to reliably and efficiently perform those interventions.
I agree with you. And so I've got a question that was texted to me. What's your opinion? This is a pretty specific transport question. What's your opinion of, for example, if we had a farther area like Springville, going from Springville to St. Vincent's East with a pediatric cardiac arrest versus going from Springville to Children's? So it's an additional 10 to 15 minutes.
You know, honestly, I think that boils down to really one thing. Personally, if it's 10 minutes, I think your 10 minutes better spent going on to Children's. I really do. Because it is a specialty center where we can do things that can't necessarily be done in other places. Because if we go to a place like just East, because that was the one they used, if they do get pulse back, what are they going to have to do?
Transfer the kid out.
Which presents its own complications and risks.
I think also when this is just transfer from, you're driving down the road, you get to XYZ, you have to unload, so you're losing quality of your compressions and airway and all.
Absolutely.
For at least 3 to 5 minutes, just getting them over to the bed.
And I would submit that we grossly underestimate that time.
Yeah, that's a complicated process, always has been.
Yeah. I think we underestimate the time it takes to get the patient from the house into the unit. I think that's more significant for adults than it is for small children, because small children are just so much easier and faster to move. I think we underestimate that though, and I think we underestimate the time we spend from, we report at the hospital, and now how much longer is it before that patient is in a room receiving tertiary?
And I think the other thing that we underestimate are our abilities to deliver high quality care. What is it, if you're reliably doing this stuff that we talked about, you've improved your training, you're reliably doing it. If you have put in a supraglottic airway, are effectively ventilating your child, doing high quality compressions, have vascular access, and are administering epi, what is the difference between the back of your ambulance and, again, I'm not trying to pick on St. Vincent's East, it was just the one that was brought up. What's the difference between the back of your ambulance and St. Vincent's East? They're not going to put the kid on ECMO, which I can do, not me specifically, but well, I can, but Children's.
Right.
They're not going to put in central lines and start doing other stuff. They don't have a pediatric cath lab if for some reason this is some weird coronary issue.
Right.
You know,
they don't have a video laryngoscope that's specifically designed for pediatric patients.
Yeah, and if it's a difficult airway, for instance, this is the beauty of the iGel. I have flexible endoscopic innovation equipment in my ER that I love and use. So if you put in an iGel, guess what I do? I put the camera down, they're disposable cameras. I put the camera down their iGel. I snip, look, make sure I'm going through cords, snip the camera, pull the eye gel, and use my endoscope as a bougie. But again, what's the difference between if you're doing these things reliably? Now, scoop and run is a whole different story because then nothing's really happening, right? We're probably not getting high quality compressions. We're probably not getting quality ventilations. We haven't achieved vascular access. Scoop and run is different. But assuming that we have changed our mentality and our training, and we're reliably and effectively doing the things and efficiently doing all this stuff we talked about, then there's little difference between the back of your ambulance and community hospital.
The thought there is the word efficient. You do this and your staff at Children does it routinely, but all of our outlying hospitals are just like us. You know, 1%, 2% of our patients are pediatric in that. So the comfort level and the expertise and the training and the tools are just all there at that facility. Unfortunately, you know, we do have great physicians in all of our facilities and nursing staff as well, but just the comfort level of dealing with a pediatric patient.
And that's where that 18 goes to 33, right? That's where that difference comes in.
I think another difference is how much training do they do in the ER? How much training do you do in your local fire departments?
We can talk about some specific emergency departments, but I actually know answers to that questions that I don't intend to put out over the internet.
Well, Dr. Duerring, thanks for a great lecture today. I think you've challenged all of us to make some improvements in both trauma care and cardiac arrest care for kids. I know we're gonna ramp up some training here in the very near future at Centerpoint. I hope that all the other agencies listening will do the same. Maybe we can even collaborate and do some joint training. Thanks again. We really appreciate your time. And well, thanks everybody for joining online, and we'll see you next time. So the password for today's class is PEDS, P-E-D-S. If you didn't click the attendance form link in the chat box, you can send an email to Alabama EMS Challenge at gmail.com. You'll get an automated reply with a link to the attendance form. Also, I've had several people asking for this particular lecture to be added as soon as possible to the YouTube channel. So I'll try to make that happen this afternoon or tomorrow. Once again, thanks everybody for participating. That's all we got. See you next time.